We can't blame communities for the certain failures. That will be the very easy escape for the administrators and experts like us to say, कि you didn't follow certain behaviors, we told you to do such and such. So, no, we can't do that because so far we have treated communities in a very paternalistic manner that we know what is good for you, we are going to feed you food through ration shops, we are going to provide you an welfare state, we are going to take care of you, give us vote once in 5 years. It's not democracy, it is demo accountancy, where once in 5 years only votes are counted.
In fact, the core design element of successful health systems is the removal of choice from individuals about where they will seek healthcare, what kind of healthcare they want. Is antibiotic good for them, or is remdesivir good for them? We as a health system will provide you the guidance of whether you need gentamicin or you need amoxicillin. It's not something we will ask you to make a decision on.
Hi, I'm Rachita Vora, and you're listening to On the Contrary by India Development Review, or IDR, a show featuring unlikely conversations on topics that affect our future. On this podcast, hear differing perspectives from leaders and experts as they help us make sense of the most pressing issues of our time. IDR is an online journal that publishes cutting-edge ideas, lessons, and insights written by and for the people working on some of India's toughest problems. You can check us out at idronline.org. Your host for the show is Arun Maira, a thought leader and author of several books on everything from listening to people not like us to remaking India. He has the unusual combination of having worked in the private sector, the social sector, as well as the government, where he was a member of India's Planning Commission. Here's your host, Arun Maira.
The COVID crisis is a medical crisis which has revealed a civilizational crisis, a crisis of governance of society, and a crisis of design of the economy. When the crisis struck the world a year ago, medical scientists jumped in to prescribe solutions and to develop vaccines against the virus. The vaccines have been developed at warp speed. We had hoped we would be out of the crisis this year in 2021. Yet, we seem to be sinking into despair again. The COVID crisis has revealed that humanity needs to find a better way to solve large-scale, complex problems. The new vaccines were tested systematically before they were permitted for wide-scale application. In contrast, lockdowns were imposed without understanding what their side effects were. The Indian government boldly imposed the harshest lockdown in the world. As a result, millions suffered in many ways, though they were being saved from COVID infection perhaps. Longer-term costs of the lockdowns are now being revealed too, such as the impairment in children's education and the destruction of livelihoods. Perhaps the more scientific approach for global systemic problems, such as those caused by COVID, is to promote more local system solutions collaboratively implemented by communities. What we want to discuss today is what should be the design of the new approach to manage the COVID crisis, and also to implement solutions to the many complex problems enumerated in the Sustainable Development Goals, which we must address even more urgently when the COVID crisis has passed. With me today, I have Nachiket Mor and Dr Abhay Bang. Nachiket is primarily focused on the design of national and regional health systems. He is a visiting scientist at the Banyan Academy of Leadership in Mental Health and a senior research fellow at the Center for Information Technology and Public Policy at IIT Bangalore, and has been a member of the Planning Commission's high-level expert group on universal healthcare. Dr. Abhay Bang is a physician and an internationally recognized public health expert. For the past 30 years, He and his wife, Dr. Rani Bang, have lived and worked in the tribal district of Gadicharoli in Maharashtra, where they set up the non-profit Search. Dr. Bang has served on various government committees and was awarded the Padma Shri in 2018 for his work on tribal health. Nachiket and Dr. Bang, thank you for being here today, despite what I'm sure is a very busy time for both of you. I do hope that the thoughts you share with us, with our listeners today, will enlighten our policymakers and all of us as citizens on how we can work more effectively together to this time address the COVID crisis in a better way. So, my first question is, in what ways do you think the overall approach should be changed? Dr. Bang, may I ask you first?
I think the COVID crisis, apart from the medical and social crisis, also raises before us the larger questions about our governance, about political and economic structure. COVID, when it arrived in Gadchiroli, the place where I live, a remote tribal area in one corner of Maharashtra, in the initial first 1 month, communities, whatever they heard from media or from the rumors, they sprang up into action. Villages introduced lockdown by themselves. They shut the entries, they prevented coming together. The sarpanch of various gram panchayat used their local funds and distributed masks and sanitizers as if the whole communities had risen together to face the challenge. But the problem never arrived. The first case of corona occurred here in May. An actual epidemic arrived here in September. By that time, people felt that this was just a rumor and nothing is really happening. There is no fear. People got exhausted with the lockdown, people relaxed, and then the real problem arrived. So, what we learn is that COVID management in India as a whole, there are 700 districts and there are nearly 700,000 villages. Each district, each village is different. So, a monolithic arrangement and administration from Delhi taking decisions about every details about every human being's every behavior with each other was absolutely inappropriate. And few medical experts, they are very intelligent, they are very competent, but nobody can be as intelligent, as competent as to govern 140 crore people. And so COVID showed us that how very centralized decision making, whether medical or whether administrative or political, tend to prove inappropriate as well as ineffective and unfortunately even counterproductive. As an article in The Economist earlier very appropriately summarized, that the COVID crisis showed us that the medical research and knowledge within 1 year really made enormous rapid advances, but our politicians and the governance structure miserably failed equally badly. And so, COVID crisis really brings us face to face in this issue of what is wrong with our governance model, with our political administration model. Now we are face to face with the question as to what new governance structure do we need. You very rightly said, local systemic solution, localization with global thinking. That slogan, think globally, act locally, is very appropriate. And we need to, having realized the limitations of centralized model, and also today's world allows us more decentralized, more localized, but connected model.
Thank you so much, Dr. Bang. And Nachiket, I have listened to you and learned from you for the last 20 years. You know things on the ground and you're one of the best thinkers about big, large global problems and thinking scientifically about them. So I'm going to ask you the same question that I would ask Dr. Bang, which is, in what ways do you think the overall policy approach, which includes scientists and experts, should be changed?
I want to build on what Dr. Bang had to say from a slightly different perspective. My background is not as a medical doctor. My interests are in health systems design and in trying to understand what are some of the elements that one can bring to bear as one thinks about what to do about our health systems. One of the core ideas of health system and almost any research and replication is that everything cannot be local, because if everything is local, then there is no learning. Then effectively what we are saying is that whenever you go to a new situation, whether that's a home or a village or a district, you begin again from a fresh slate, from a fresh perspective. My view is there is no doubt that there is a room and an enormous opportunity to do that in order to be effective. But there are indeed common elements that are statewide, nationwide, or worldwide that actually can be brought to bear. And that's something that my understanding is now an evolving consensus in the world is that comprehensive, high quality primary care has to be the bedrock of any health system. And by this, I do not mean only community organized care. I mean also experts, also expertise that is brought to bear on the ground as we think about how to solve peculiar problems. The best designs, and Dr. Bang's work is one model of that, and there are other models. Costa Rica, for example, is a country that's done a wonderful job of this. Cuba has shown us the importance, for example, of home visitation. Even in the US, you're starting to see the use of human resources that are not necessarily MD physicians, but nurses, hygienists, community health aides to do this work. But the common element is that they provide an integrated, comprehensive care informed by fairly deep expertise. My view, for example, is that health specifically, there are many aspects of community that are involved. In fact, the core design element of successful health systems is the removal of choice from individuals about where they will seek healthcare, what kind of healthcare they want. Is antibiotic good for them, or is remdesivir good for them? The core design elements very much are, what you need to do. We as a health system will provide you the guidance of whether you need gentamicin or you need amoxicillin. It's not something we will ask you to make a decision on. Now, this balance has to be struck well. If we go the other extreme and say, let the community figure this out, I would submit to you, you will get the kind of variation and response that you saw on COVID-19. The challenge for us in India is that partly, perhaps it is, all of the broader issues that were raised earlier, but it's also that we have not built the comprehensive primary care system that is necessary. So while we are anxious that perhaps excessively centralized, overly centralized direction is being given, the reality on the ground is that communities are being left to their own devices. There isn't really that much care available to them. So they don't actually see that centralization play out, except when it's a national decision like a national lockdown where people are forced to migrate. But otherwise, on the ground, my experience is most people are left to figure things out on their own. And in fact, it is communities operating on their own, trying to do the best they can. Unfortunately, and that's the point I want to make, it's not enough. You do need expertise. You do need people out there that are from the center. Now, the center could be district headquarters, could be national headquarters, that are available on the ground with the expertise, with the capability to provide the services that are needed. Otherwise, we're not going to get good healthcare outcomes.
Thank you. I can see now the challenge here, Nachiket. As you said, we need both. Very, very clearly, and you're endorsing for very good reasons, scientific reasons, why the local approach that Dr. Bang has explained so well is essential to a global solution. But you say that if every community is going to keep finding its own solutions, we are not going to be learning from each other. So there is here the need to think of the whole global system as a learning system. And in the learning system, there's a necessity for local thinking and local action. So I'm going to just say that both of you have affirmed that this organic way of a system learning together in which the locals learn as well as the scientists observing how the locals learn also learn is the right way. But why is it that government, top people, and even present scientific experts resist this idea of empowering local learning and helping local communities to learn.
I must begin first by stating that I agree with Nachiket on this, that new knowledge, new learning happens world over, and everybody doesn't have to rediscover the wheel. And that's why we need a system where learning can be disseminated, not forced down upon. So we need global thinking and then local action and a free flow of knowledge learning that ought to be one of the basic human rights of everybody. But when it comes to your own local situation, maybe the local community has the best judgment as to, after knowing everything which is available, what is best choice and best path for me. Now, coming to your question, Mr. Myra, what prevents us from this? I would enumerate few factors, and not necessarily I will be very comprehensive. But one factor is, I would say, that the philosophy, the liberal philosophy, worships individuals, and then next to individual is the state. There is nothing between the state and the individual. But there are communities between individual and the state. But liberalism, to a large extent, either forgets or ignores communities. India's constitution, when it was designed in 1949 and 50, was led primarily by, if I am allowed to say, by Jawaharlal Nehru and Dr. Ambedkar. Both were products of European Enlightenment. And though I am too small to make any comment, but I think both of them were unduly impressed by the Euro-American, more so European model, and both of them almost despised Indian villages. And both of them were open about it. In the constitutional debate itself, when somebody pointed out that the whole draft that you have proposed, there is no place for villages, village community, Gram Swaraj, Gandhi's dream, Dr. Ambedkar replies that what are villages? They are dustbins of ignorance and casteism and colloquialism. Because of his unfortunate bad experiences, which were true also, with Indian villages, caste system, he was very much against Indian villages. Nehru, because of his Eurocentric model and exposure to Russia, he also disliked Indian villages. Both of them practically kept Indian communities out of the Indian constitution. So one major hindrance is our lack of trust in the communities, in the wisdom of the communities. Few years ago, there was a very interesting book, Wisdom of the Crowd. And it pointed out that a group of illiterate people or not very professional expert people, but when they are together, they discuss with each other with free flow of information. The conclusion they come up with is equal to or often better than the recommendations of an expert group. So we ought to trust, have some faith in the communities which neither liberalism has nor Indian constitution and Indian administration has. And we completely forgot the ability of Indian villages, which have really withstood nearly 5,000 years environment and aggression, everything. We did not leave any scope for their empowerment or their local initiative. We saw that in Corona, that's where we have started rethinking. You very rightly said, Mr. Myra, long ago, of course, Mahatma Gandhi had propagated every village as a republic, but doesn't mean every village is free to do anything. They were to be interconnected with each other and also with the state and the central government, was what he described as oceanic model, not pyramidal. There are no different levels. Everybody is on the same level. In a silent pool of water, if you drop a stone, you get waves. There is a center and there is an intermediate wave and there is a periphery, but all of them are on the same level. Now, interestingly, because we think and speak in English, we miss a lot of the richness of Indian culture. But Mahatma Gandhi's grandson once asked me a question. He said, you have studied health and public health and so on and so forth. What is Indian definition of health? And I blurted out WHO definition. He shut me down. He said, tell me Indian definition of health. I didn't know. So he said, what is the word for health in Hindi or in Sanskrit? Swastha. जो स्व में स्थित है वो स्वस्थ है. What a beautiful definition. The word itself carries the definition. It defines health as freedom. It defines health as autonomy. It defines health as responsibility. So we need health. We need swastha, not dependence on others. That would be aswastha. So we designed this model of Arogya Swaraj, where people, where communities were truly autonomous, responsible themselves for their own health and taking care of each other's health. That doesn't mean not using science. We use science from the world over. We did not rediscover antibiotics. We did not discover again X-rays, but we use all this global scientific knowledge but gave it in the hands of local communities like a community health worker. And community health worker provided health care at the village level. And though not all, and Nachiket is right in saying that we need a comprehensive primary care, everything cannot be managed at the village level. I'll give you one example. When you came here with my arrogance, medical arrogance, as well as I had just come back from the US with public health degree. So when I saw sickle cell disease here, we headlong jumped into doing research. And when everything happened, it was published, it received government awards, but nothing happened. Villagers said, this is not our problem. You came and you asked for a drop of blood, so we gave you a drop of blood. But what you are talking about sickle, we don't know what this is, and this is not our problem. So we realized that our expert approach, we had blundered to force upon the people our intellectual priorities. So we kept those aside, called a People's Health Assembly, invited representatives from 50 villages, and humbled by this first experience, we asked them, now you tell us what are your health priorities. We will try to address them. Now look, 30 years ago, they gave us 6 priorities. 3 of them were well known even at that time: malaria, diarrhea, and child mortality. But 3 priorities which people of Gadchirli told us at that time were unheard of in the field of public health. One was, they said, backache. We have enormous backache. Second priority was alcoholism amongst men. And third priority was women had white vaginal discharge, which is called padar in local language. Now these 3 issues at that time were nowhere on the horizons of public health, global or national. But local people gave us these 3 priorities in addition to, as I said, malaria, diarrhea, child mortality. We have been working on these 3 other priorities also for the past 30 years, and now Global Burden of Disease study tells us that backache is probably the second most common global morbidity, which people of Gadchirli told us 30 years ago. Alcohol and tobacco are now 2 out of the 7 topmost causes of risk factor which cause death, disease globally. People of Gadchirli told us 30 years ago. And women's reproductive health. Women were telling us in Gadchirli that we have this vaginal discharge problem with such a shame which we can't reveal. It later on became women's reproductive health policy globally, but people of Gadchirli told us even earlier. My point is, people know much better what they need, what their problems are. They may not know all the scientific causality, they may not know all the possible solutions, but when it comes to deciding priorities and when it comes to deciding local implementation, probably people are the masters.
At this point, we'll take a small break and we'll hear more from our guests on the other side.
There are few words that can describe what's happening in India today in relation to the pandemic. No matter where you sit or what your personal situation is, things are really hard. And it's easy to feel helpless and hopeless, to want to help but not know how to be of service. At IDR, we've put a list together, which shares information about non-profit organizations who are at the front lines of the fight against COVID-19. We mention what they're doing, where they're working, what specific support they need, and how you can help. If you'd like to check it out, you can find it on our website, idronline.org. Thank you for listening and take care. And now, back to the show.
And Nachiket, you are now most well informed public health, if I can say the word, experts that I know of, really, because earlier on you spent so much of your life helping with new systems to help people earn better livelihoods. And one of the problems for India has been that the solutions that we've applied medically to prevent people from being infected by the virus have hurt their livelihood so badly. So I'm coming now to action. Nachiket, India must get through this crisis, which has got many facets to it. And yes, we need more local solutions, as you pointed out, the best learning across the system and from elsewhere too. What would be the architecture of our response to the situation that we are confronting, which will ensure all round well being improvement of people everywhere, their incomes, their access to other things that they need, and also, of course, being safe from COVID?
I personally believe that this is a little bit of a false separation between expert and community. Good expert systems run purely by scientists do not take solutions manufactured in district headquarters of Gadchiroli and bring them to the village of Gadchiroli. I think that's bad science. I don't think that's good science disrespecting community. If I look at good primary care, Britain is a model that experimented with this quite a lot. Cuba, as I mentioned to you earlier, is somebody that we all look up to, is very much deep experts, understand local epidemiology, local disease burden, and respond to it through surveillance, through engagement, through talking with people. In fact, this whole idea that a single primary care physician or a primary care practice with community workers and family health teams should look after no more than 3 to 4,000 people comes from that underlying belief that you have to understand what is happening to your patient. But I worry a little bit that if we flip that and say the community knows, while not seeming to do so, we are now transferring blame to the community. Why are you not well? Well, you didn't do a good job. You should have known better. And I have heard, for example, even in this COVID time, this anxiety expressed by a number of experts to say people didn't wear masks, what can we do? Right? People didn't follow COVID appropriate behavior, what can we do? I worry about that. I certainly believe that if systems are failing, it's not the community's responsibility. Community is a partner, I do not deny that, but I worry a little bit with the view that they are responsible or that they have superior knowledge. I remember going to a project in one part of India where somebody had actually literally experimented with this, had given the panchayat money and said, build the health system that you think is appropriate. Almost uniformly across the panchayats, they had shut down the PHC, they had bought ambulances, and their view was, oh, this is all rubbish. We're going to send everybody to the nearby city whenever they have a problem. And frankly, I was not surprised at that. Why is it that we believe that this group of people, based on what they understand, would know the value of what we call primary care? They want something that they know works. What they know works is going to a hospital. In fact, and we are talking about rich and poor people. Some work I have done, and the evidence base is still not as strong as Dr. Bang would approve of. But I compared Germany and France. Right? You would argue both are similarly developed countries. I find France spends 20% less than Germany and has 20% better outcomes. The one difference that I see between the two systems, French take away choice from their citizens. You have to go to a primary care provider before we will allow you to go to the hospital. You don't like it? Well, too bad. We're not going to ask you. We're not asking you. Right? We will make you do this. Right? If I look at inflation, Taiwanese, Swiss, Japanese, good health systems, out of control inflation, of course, because they allow their, individuals the choice to do whatever they feel like doing. And unfortunately, in healthcare, given all the asymmetry that we have, we end up making choices that are not necessarily very good. Now, the question is, how does this translate into what needs to be done on the ground? Again, Dr. Bang has the expertise. I do not. But there are some narrow pieces that, I certainly am hearing again and again and again. I've been writing about it since last year. The Italians when they went through one of the most visible, kind of meltdowns in Lombardy, they wrote and wrote and wrote, requesting us, do not rely on hospitals. Work much more closely with primary care systems. The idea was, and we know now from the data, that 80% will get okay on their own. 80% of those that fall sick will need basic care, which includes medicine, but also includes, importantly, oxygen, which you can give in a home, you can give in a primary care setting. The cost of that nationwide is less than 1,000 crores. Large amount of money for any individual, but not a large amount of money for any systematic approach at the state or the national level. Yet, most of our facilities do not have this basic element that is useful not just for COVID-19, but for tuberculosis, but for maternal and child health, and for many other aspects. I would submit to you that if we are mounting a strong response, let us do our job. Let us make sure communities are operating in unconstrained environments, and then turn around to communities and tell them, I know some of what we are saying may not immediately make sense to you. We will try to explain it to you. But the element inside it has to be trust. You have to trust me to do what is right for you. I'm not persuaded that the wisdom of the community will figure out an answer to this solution. I do not believe that it will. It will need engagement from experts to deal with most of the issues that we face today. These are not things that, even from evolution, cancer is not an evolutionary disease. It's new. We were designed to live much shorter lives from an evolution perspective. And these are areas in which science will have to prevail, and community engagement will have to be as a client, as somebody that I'm working with, somebody I'm listening to.
Right now, Dr. Bang, since we do have a crisis, COVID crisis, what would you say are the important changes in ideas and first steps we must make to change the paradigm with which we are improving public health in the country?
I must begin by stating that I agree with Nachiket on two counts. One is that yes, there are certain pieces of knowledge which are like basic science knowledge. We don't expect community to do molecular research or find out new drugs. So knowledge has to be freely shared, and we don't have to romanticize communities that they know everything. They'll find out everything. But what happens, let me tell you one example, when communities and experts really interact at the equal plane. When we sat in People's Health Assembly, and then, as I said earlier, people said malaria is our problem. So we offered them that science teaches us that there are three kind of solution: indoor spraying with insecticide, use of bed nets, and diagnosis treatment of every fever case. So they said, what is the use of spraying? When these government people come and spray, we immediately wash our walls again. So we told them, look, spraying kills mosquitoes. So they asked us, what has mosquito to do with malaria? Our problem is malaria, and you are killing mosquitoes. So we told them mosquito bites spread malaria. They said, my God, we never knew this. 100 years after Ronald Ross made that discovery, the knowledge had not reached to the people of Gadchuli, whose number one cause of death was malaria. When we told them that this is how malaria spreads, they were, oh my God, then we do want indoor spraying. And that's why we will use bed nets. And malaria program that we developed with the tribal people of Gadchirli, we have been going through successes, failures, but in the last 20 years now, malaria incidence has come down to 10% of what it was originally. No, but the example I gave was, it's beautiful experience when expert and communities interact in this way and exchanges, diffusion of knowledge occurs. We pick up priorities from them, we offer them solution, then they ask you questions, then you satisfy some of the solutions they might reject. We have to accept that it might not be suitable for them. And that's how the community expert dialogue. So second thing that I agree with you, Nachiket, is that we can't blame communities for the certain failures. That will be the very easy escape for the administrators and experts like us to say कि आपने you didn't follow certain behaviors, we told you to do such and such. So no, we can't do that because so far we have treated communities in a very paternalistic manner that we know what is good for you, we are going to feed you food through ration shops, we are going to provide you an welfare state, we are going to take care of you, give us vote once in 5 years. It's not democracy, it is demo accountancy, where once in 5 years only votes are counted. People have no scope to participate in the everyday affairs, everyday decisions of their life. Our whole administrative model is that the central government keeps all the budget, it doesn't pass it on even to states, even for vaccination. The 35,000 crore rupees which were announced in this central budget has not been passed to the state. Forget about the districts and forget about the villages. So then we need to really, because everything in the world is interconnected, there cannot be health system independent of the economic system and political administrative system. We need to rethink about the model. So in the current corona situation, what could be done? Coming back to Mr. Myra's more pointed question, as I said, we initially saw communities really had a lot of initiative and action. It was impossible for me to believe that when the migrant labor started coming back to their own villages in villages of Gadchiroli, most of the villages kept them for 15 days outside in a hut or in the school building, didn't allow to enter in the village. They provided them food there. Communities organized to provide food to all migrant labor who were coming in the village. So communities, when provided with some information and given role at that time, because administration didn't exist at the village level, they did that. And then there came the central road roller and the collector SP Raj, and the collector and superintendent of police took all the responsibility, and the villagers then became apathetic. They become paralyzed. They just had to follow the lockdown orders, but they were not given any scope for local initiative and action. Now, if imagine if we had involved whatever 300,000 gram panchayats that we have today and their local leaders in implementing the behavior change and the lockdown measures, distancing, etc., and also the SHGs, and also the civil society. Civil society is practically nowhere in this management of corona epidemic. Civil society in India as if it doesn't exist. You take only orders from few experts in Delhi. Collector gives you order. He tells you that from today onward we are taking over your hospital. Now he is doing it. He is following, obeying the order which he is getting from above. This is a very authoritarian model of trying to control corona, which is currently problem of 140 crore people. Make it a problem of 140 crore people. Let them know what they are expected to do. I am sure they will not do it 100%. But then communities evolve their own norms, their local initiative, the Gram Panchayat and the Sarpanch and the village women leaders, SHG leaders, and civil societies. Of course, they can't generate vaccine. They can't generate new medicines. That scientific product has to come from whatever level we all know. I don't want to call it above, but it has to come from the government, maybe inside or outside India. So we need a participatory model. We need a facilitatory model where we use the power of 140 crore people and 7 lakh village communities.
This has been so powerful and for me, so uplifting what Dr. Bang has said. But I want to know what you're going to say. You are our other expert here.
One view to take is, the dismissive one. I wouldn't necessarily call it the scientific one, is that they don't know what they're doing. They're just not smart enough. And, unfortunately, this is their problem. Right? On the ground, though, there's some work that I'm associated with on ritual and culture and understanding what is going on inside the household. It turns out the well-being of the mother, the well-being of the child is of central importance to the family. It is not a peripheral matter. In fact, one of the reasons why change is hard is because now you're telling somebody that I'm going to go after what is central to your life and I'm going to tell you what to do with no respect and no cognizance of what you're doing yourself and what you're invested so deeply in. And often, even the people who have been assigned to communicate this new knowledge themselves don't believe it. The research shows that if you ask them, what practices do you have? The communicators, well, their practice is not that different from the ones that they're communicating to. So it's no wonder that you're not getting the kind of impact that you need. So I'm, very much of the view that any work that is done on the ground will have to bring that ethos to bear. I would also say that, yes, we are all taking the view that government has a role to play. In health, though, for a variety of reasons, one could say good, bad, whatever. Indian governments, state governments mainly, have chosen to deprioritize health. And as states have gotten richer, they have, across political administrations, have reduced their commitment to health. A state like Maharashtra, for example, as a proportion of its GDP, spends less than some of the poorer states do, for example. And this effectively means that, in fact, the communities and local organizations are left to their own devices. And if I have a concern, my concern is that a lot of these organizations have not taken on that responsibility. They have waited for donors, they have waited for governments. Communities are spending thousands of rupees on taking care, going after care. They don't need, it's not adding value to them. But yet, you don't see a community organization step forward and say, we know that you are doing your own healthcare. Government is really not playing that much of a role in your lives. I'm going to sit with you and figure out financials, healthcare, delivery, and all of that. And I'm persuaded, from whatever little I understand, communities are spending enough money on healthcare. If we organize that better, we could offer them much better services. Now, it's not ideal. Ideally, actually, you want almost the opposite of what we've been discussing. More involvement of the government, more involvement of the powers that be. In fact, we have the opposite. Most of the time, even in the core business of delivery of babies, which has been a stated agenda of most governments, the governments have basically told people, you figure it out. If I look at mortality, you'll see in the infant mortality number, while we are all happy infant mortality has fallen, the rate at which neonatal mortality has fallen is far slower. Within that rate at perinatal mortality has fallen is even slower. Most of the mortality has fallen post neonatal mortality after 1 month, because their communities have taken charge. They know what to do. They know how to figure it out. It's really when the medical system is involved, right? Things haven't actually moved forward. So I would say, and I have written elsewhere as well, even at the level of the private sector, I would submit to you, health is one unusual area. I used to be a banker in my previous career. Health is one unusual area in which the formal private sector is a very tiny part of the health system. So I would say, in part, yes, while we are very focused on what the government could do differently, I would submit to you community organizations and the private sector could also step forward and say, it's my responsibility. In fact, that's been one of the issues that I have been a little bit concerned about in healthcare. And I do agree with Dr. Bang that we should not blame the community. But oftentimes I see kind of a bimodal response. Government is responsible, community is responsible. I would very much want a lot of organizations, particularly community organizations, to say, I am responsible. I am there. If it's not working, I have failed. Because my people are spending enough money. I have not helped them organize what they are doing with that money well.
I get it, Nachiket. As you have been pointed out from your knowledge and experience of things around the world, you can, if I could use the word, over-privatize it or over-governmentize it. You need to have the community at the center and government playing a role and the private sector together, all three partners playing a role in the interest of all citizens of the country. And even the people of the government themselves as human beings, as the people of the private sector as human beings, need health, public health. It's something universal. So we have to cooperate together. But the lesson comes again, which you said again, affirming what Dr. Bang said, the community is at the heart of it. It is their health. And unless they are empowered to take responsibility for their own health, we will not be able to help improve public health in India. So thank you both very much for a very, very illuminating discussion today. Thank you.
On the Contrary is produced by Aisha Marfatia, Smarnita Shetty, and me, Rachita Vora, with additional support from Kuber Batla. This episode was hosted by Arun Myra for IDR. Production by Made in India. To learn more about the kinds of ideas featured on this podcast, check us out at idronline.org. If you like our show, subscribe to us wherever you get your podcasts. You can also recommend the show to someone you think will like it. Share it with a friend, colleague, or someone in your family. Or leave a review on Apple Podcasts so more people can find out about us. Thank you for listening, and see you next week.